No reira, tēnei te mihi ka koutou katoa, kua tūhono mai I te rānei, tēnā koutou. Me taku mihi ki a tātou kai kōrero I te rānei, a Dion, Rawa, ko Daniel, tēnā kōrua. Hei aha, hei whakātu I tihi a wangawanga I a tātou mō te mahi I roto I te tatau o ngā nama me ki I roto I te Ministry of Health. Anō reira, tēnā koutou. Ka tīmata I te karakia, apuhia, hurihia, taku whakakoro ai tā whakinui āhema. Tēnei ka iki ki te hunga, takupu nui, takataka tū te rangi, takataka tū te whenua. E puta rongorongo hau hau, māma no aki ke māma puta oho oho hau. No ngā ariki, no ngā pukinga, no ngā wānanga. Kiu ki tēnei tauira, kiu ki tēnei wānanga, whānau whanake, tū mai te toke, haumi e, hui e, tae ki e. Kia ora tātou. Kia ora tātou. So my name is Taka Keegan, and I'm one of the leads in a project called Tikanga in Technology. And it's the Tikanga in Technology, the TINT project that is running these Whāki web series. And today's Whāki web series, we're pleased to have two really cool guys who are looking at algorithms, the decolonizations of algorithms as a general topic. But they're here today to talk to us about some issues that we're having with health data. They came up with this really cool title, Whitewashing Health Data is Killing Māori. I don't know where they came up with that from, but it's a really cool title because that's kind of what's happening. Okay, so we've got Dion O'Neale and Daniel Wilson, both from the University of Auckland. No, I tupu mai a Dion I konei Aotearoa nei, engari no Ngāti Pākehā a Dion. Ko Daniel tupu mai anō I konei Aotearoa nei, no Ngāpui, no Ngāti Pūkehā a Daniel, no reira. Koe nei a Rawa, ko tai mai te rānei ki te kōrero ki a tātou. So what I'm going to do is I'm going to pass it over to Dion to start with his presentation. Dion's going to talk for a little while. He's going to pass it over to Daniel. Daniel's going to talk. They're going to pass it. He's going to pass it back to Dion. So we're going to have a conversation highlighting some issues that we're having at the moment with our health data as it pertains to Māori. We're going to have a conversation between these two gentlemen, and then hopefully if we get enough time towards the end, there'll be an opportunity for some questions. So if you can think of some questions, please type them into the chat box. I'll have a look through them and try and summarize it and find time at the end to ask those questions, or there might be an opportunity just to free-fall some questions. We'll see how we go. Again, if you've got any questions, please add them to the chat box. Also, please add to the chat box your name and where you're from. So we've got a bit of an idea of who's tuning in, who's listening, and if we want to follow up with some points, who we can follow these points up with. Please note, this is being recorded, and we hope to make available the recording on the Whāki web series as well, sometime in the future. Okay, enough from me. What I'm going to do now is pass it over to Dr. Dion O'Neale and Dr. Daniel Wilson. Tēnā kōrua, kei a koe Dion.
Kia ora. Thanks to Taka. Thanks very much for the invite, and for also thanks to Natalie for setting this up and making this all work. So yeah, let's see, hopefully you're all seeing a screen now. Great. Yeah, so as Te Taka mentioned, so I'm a Pākehā network scientist, and until 2 years ago was interested in anything that happened on a network, including some spreading processes on networks. And 2 years ago, everything became about that spreading process being the spread of an infectious disease, COVID-19, and about how we could take an approach to modelling that spread in a way that tried to address what I thought were some of the big equity concerns that were going to come up over the we didn't know how long it would be, but over the years following the arrival of COVID in Aotearoa. And
So we might pass it over to you, Daniel. See if you can take up from here. Thank you.
Kia ora te taka. Kia ora koutou. Let's see if I can share. We're going to tag team anyway, so this this all works out okay. So I got involved in Dion's sort of other broader project. I'm also in the Tikanga and Technology project. So you can see here, I'm just going to talk about one of the papers that's underway at the moment. And there are a number of people involved, of which I'm one. But the idea here is just investigating how the current Māori vaccination rates are on. Oh, Dion, you're back.
yeah, do you want me to jump back in? Sorry, I don't know what happened there. My Wi-Fi just vanished. Let me see if I can. Or do you want? You're on the roll, Danny. Why don't you just go from here?
All right, I'll just run through the vax rate stuff and then hand back to you.
Yeah,
okay?
Let's go with it.
Cool. All right, so the title, Whitewashing Health Data is Killing Māori. I know where we got that from. That was Te Taka. Snappy title. All right, so I'm just going to do a little bit of setup of population here, just to give you an example of how the vax rates are calculated. This kind of extends on some of the points that Donna Cormack raised last year about problems with overestimating Māori vaccination rates and the implications of that for under-resourcing the vaccine rollout. Okay, so here, let's say what we have here is the total Māori population who are eligible for vaccination. Probably the best guess number for that is from the estimated residential population figure, and that's based on census counts. And the further away you get away from census, they add births and deaths and stuff like that to give you an updated estimate. But of course the census, our last census was 2018, and that was a bit botched anyway. So the ERP is one figure to note, but we'll come back to that in a little bit, because another vital figure is the HSU number. So this is the count in the health system effectively that's being used for calculating vaccination rates. So there's an HSU database, and you are counted as Māori in this database if you have engaged with the healthcare system, with a primary health organisation in the last 3 years, and you are Māori on your NHI record. So that leaves out some people, right? Some Māori who will not have engaged with the health system in the last 3 years. So I've sort of drawn a line around here to indicate there will be, of the total Māori population, there will be some who aren't in the HSU database, right? And that'll be relevant for how the vax rate is calculated. So this might be a number of things. It might be due to accessibility. There's a fair bit of research on that. Now I've also got a group up the top here who are Māori who they do have NHI records, but ethnicity might be recorded incorrectly. So that can occur, for instance, if you visit a GP, maybe GP makes an assumption about your ethnicity and inaccurately records it. So that means in the HSU count, the system won't know that that these Māori in the top right-hand corner are Māori. Okay, so that's the next step. So what this means is that the HSU count is always going to undercount the number of Māori in the system, likely. So here's a graph that shows for a number of different populations. If we take that estimated residential population and we subtract the health service utilisation number, which the latter one is the one that's used for calculating vax rates, you can see that here the estimated residential population is higher for Māori in the top right, right? So if you're using the HSU to count vax figures, that number is not going to be an accurate estimate of the number of Māori who are eligible for vaccinations. You can see it's different for different populations as well. Sometimes it goes the other way. So Asian populations in a similar situation to us. Okay, so in the setup, we've got, out of these 40 individuals, only 32 are in our HSU database. We've got 4 who are in HSU as non-Māori and 4 who don't interact with the health system. If we make an assumption that there's something like 75% vax rate, just for illustrative purposes, I've plotted a number of people in purple here to say that they've been vaccinated, right? Just to give a bit of an image that we can use for running through a couple of scenarios. Okay, so overall, out of these 40 people, 30 will be vaxxed, but the distributions will be slightly different. And you've got the breakdowns here. Of the 32 Māori who are in the HSU database, 25 are vaxxed. There are some who don't interact with the health system. They're in yellow here. Perhaps they might have a lower vaccination rate. And then there are other, up the top here, we've got Māori who are incorrectly classified, who also got 75% vaxxed. So let's now take a look at how the vax rate's currently calculated. So here's our population on the left. In that black dotted line, that's what is recognised as our Māori HSU count. Well, that goes on the bottom. That's the denominator there of 32. And what we're picking up here is not only Māori who are in the HSU count as Māori, but also we might have Māori who come in who haven't interacted with the health system, and so who aren't in the HSU database, who have a new record created. So they're also added to the top total. So what we've got up here is calculating the vaccination rate. Māori who are in the HSU count plus some Māori who aren't in the HSU count, divided by the total HSU count. So we assumed in our setup here, you can see in the picture if you do the count, that 75% of the population are vaccinated. But using this kind of calculation, you're getting an over count of the Māori vax rate. Right? So the calculation here works out to 84% on this illustrative example, whereas the true vax rate, we said, is 75%. And that has big implications, because when you've got differences, I mean, here it's there's quite a stark difference of 9%. Well, that's quite a large percent difference when you're thinking about how many people are left to get vaccinated. So if you think you've already vaccinated a huge proportion of the population, well, then you might under-resource efforts to continue rolling out the vaccination, right? So there are various other ways that we can change this vaccination count. I've got a number of different slides here, but I won't go through them all in detail. So here's one. So let's say now we're excluding those who were discovered, that is those who have new NHI numbers from the vaccination rate, and only including in the calculation those Māori who are in the HSU population. So this would still give an overestimate, and it's also reliant on comparable vaccination rates from those who aren't in the HSU system. So that 78.1% is a bit closer. In fact, all these other ways of calculating are a bit closer. Here's another method. Perhaps why don't we include those who have new NHI numbers who have been picked up in the system now? Why don't we include them in the denominator? Right? So now they're in the denominator and the numerator, and that also gets somewhat closer. But that's still an overestimate. Right? So there are different ways of doing this. Another option could be to ask people when they get vaccinated whether their ethnicity is correct. So you can update, potentially update ethnicity on their record. And that would also give you more information to get a more accurate vaccination rate. And another option could be to use the ERP figure and use that as the denominator. So that the ERP figure, if you recall, is the best estimate we've got of the Māori population who are eligible based on census figures and updates. There are some problems here because how ethnicity is captured in census and other administrative records might not be the same as they are in the health system. So you might end up with a mismatch in some cases. And with the different scenarios we've got using this ERP figure, you're going to end up probably with an underestimate of the vaccination rate. But that's okay. If you're underestimating the vaccination rate slightly, you're still more likely to put sufficient resources into the vaccination program. So probably that's all I need to say about this. Really, the main points is that the current way of calculating vaccination rates for Māori are pretty awful. They overestimate by a lot, and there are some modifications that you can do to get that estimate a bit closer to the real figure. Anything to add there, Dion?
No, I think that's a really good coverage of it, Daniel. And the part of the reason we've ended up with this situation with using this weird HSU population is because if you're trying to use that for the traditional way where you try and allocate health resources is you want to say, oh, we know about this many people who have, for example, kidney disease, and there having an underestimate of your total population isn't such a bad thing because it means you're over allocating resources for those. If you think there are 10 people who have kidney disease and 100 people in the population in total, you over allocate resources. In the situation where what you care about is the people who are not having something allocated to them, specifically the condition of being vaccinated, then things are swapped around, and so suddenly you've got the thing where you're much safer to be underestimating your coverage rates rather than overestimating the prevalence rate of a health condition. So it's health have taken a method that might work well if the thing that you're counting is a health condition, a negative consequence, and replacing it with the status of being vaccinated, a positive thing in terms of a health respect. But yeah, not updating a methodology to acknowledge that change has left us with this situation with this underestimating or overestimating coverage rates.
All right, I'll pass back to you, Dion.
Okay, let's see if I can do better at sticking around this time. Okay, share that. Sure. Right. So now that Daniel's given you the guts of where this thing's heading up, I'm going to start by going back to the introduction. So if there's only 3 things you take away from this talk, what I think are key messages are, one, that a bunch of the traditional modelling, traditional analysis that gets done around infectious disease epidemiology assumes you've got a homogeneous population, and that population has homogeneous interaction patterns. And because of the situation we're in Aotearoa, when things are homogeneous, it typically also means white. So basically you go and replace any information that might be specific to individuals with what looks like the white average for Aotearoa. So you can say, okay, we're going to do a little bit better than that. We're going to try and do some better analysis. We're going to make models that are specific to the population we have. But those models are only ever going to, and analysis is only ever going to be as good as the input data that goes into it. And so what Daniel just presented was this perfect illustration of, even if you have your algorithm there is literally just calculating a percentage, it's saying what fraction of the population of one group in the population is vaccinated. When you've got junk input data for estimating what the total population looks like, you're going to get out junk results on what that coverage calculation is. And obviously that applies in a bigger range of situations as well. And so all the way from using that poor population data, which has consequences for that under-vaccination calculation, you might think, oh well, vaccination is sort of a solved problem now, or it's where we've sort of settled down to whatever that vaccination rate is. We've moved on. There are other issues now. Surely they're not repeating the same thing we've learned from what we did with vaccination. But no, we didn't. So there's, when it comes to information about who is infected, we're equally, or we're, I would argue, in a worse situation than what we were with the vaccination information. Right, so this is trying to set up the context for why we were looking at vaccine data in the first place. So this was a project Te Matatini o Te Horapa, where we went out to build a big population-based contagion network for Aotearoa, and the goal being that if we can build a more detailed model for what disease spread looks like in Aotearoa, then we can better answer questions around equity and the burden of disease in Aotearoa. So first start with what normally gets done when people try and model an epidemic. So a traditional epidemic model has people move through some states of disease progression. They start out susceptible, they might become exposed after they interact with someone, they become infectious at some point, and hopefully in the future they either recover or are removed from the population. And these traditional models, they make two assumptions that kind of get lumped in together. So first thing is they assume a homogeneous population, or that everyone in one box behaves the same and has the same attributes, the same likelihood of risk and the same consequences of risk. And they also assume that the people in that box are well mixed. And so what that means is basically they're assuming that the people are bouncing around, interacting with each other at random, as if they're just particles of gas in a box or something. And clearly this is not true. So if I'm in Auckland, I'm less likely to interact with someone in Dunedin than I am with someone else in Auckland. So these interaction patterns matter. And I'm more likely to interact with someone at the University of Auckland than I am at AUT over the road. So these are two broad assumptions that wash out the details in traditional epidemic models. So they've got consequences. So just as a really toy model, there's two curves here that are trying to show either the cumulative number of people who are infected or the number of people who are actively infected at any point in time. And there's a brown curve on there that represents if you went and took one of these well-mixed models, just assuming everyone interacts at random. And all the coloured curves in there are different examples for what's called a network model. So that assumes that people interact on some kind of contact network. You've got the pattern of people who you bump into every day, and you interact with them and they interact with their contacts and so on. And you can, like, not drawing anything into the particular details of these, but just wanting to make the point that there's qualitatively big differences between that well-mixed model and a model that assumes that people have specific interaction patterns. So that's kind of said, okay, well, networks seem like they're something that matter in the background of all these, so we should build a network contagion model. And the way we did this was we went and made one individual in our model, trying to represent one person for each person in New Zealand, and we give each person some individual level attributes, age, sex, ethnicity, so on, and we give them an explicit set of other people who they interact with. So in this example here, the green person, they're supposed to be an infectious person, D down the bottom there. They can infect the susceptible person E, the person on a bike, but they can't directly infect the person A, the person in a wheelchair, because there isn't a direct interaction pathway to them. They don't meet face to face. So this is the sort of the backbone for this, taking a network approach to an epidemic model. What we actually do, in fact, to model this is something a fraction more detailed. We go and we say that people interact with one another in specific contexts. So you either interact with people because you're sharing a house with them, or maybe you're sharing a workplace with them or a school with them. And so we connect up individuals with the context where they interact. So in this case, our individuals A, B, C, and E, they're all living in the same dwelling together, and C, E, and D are all going to the same school together. And so this gives us a little bit of extra information about the types of interactions people have as well in our model. There's another reason we do things this way, and it's because actually what we have information about isn't who people meet face to face, but where they go. So that's things like, we know that people live in dwellings. We can get this information from census, where dwellings of particular sizes and particular age structures in particular locations around the country. We can use information again from Stats New Zealand, from both census and from tax information about people's workplaces. So we know that they are going to a particular location for work, and similarly for schools. And so we build up this network that has these different layers in there. So the key ones being dwellings, workplaces and schools, and then this fourth layer that we try and put in all the other types of interactions that people have, whether it's going to church, going to the supermarket, going on public transport, going to marae, anything else that isn't covered in those first three. Obviously there's going to be some limitations there, so we're building this model around official statistics, mostly census and education and tax records, plus some other third-party records for that everything else layer. But it gives us more information than if we just assumed everyone was homogeneous and interacted with everyone else at random. So, for example, it lets us capture some information about household structure. So these charts here, they're a little bit confusing, but what they're trying to show is, so we've got our population broken down into 4 different age groups for the 4 charts. And then we're looking at, for dwellings of each size, the x-axis is the size of dwelling, and we could say, look at the people who are of age 0 to 14 and in a dwelling of size 3, that's that third bar along there, and we go and say, okay, so what fraction of the population are in a dwelling of size 3, or population in that age? And this is saying that about just under 3/4 of other, so that's European plus Asian is making up most of other in this ethnicity breakdown, are in a dwelling of size 3, and what we go up to a dwelling of size 10, well now suddenly it's only about 25% of that population is in a dwelling of size 10 and ethnicity other. So, and those dashed lines running across there are what we'd get for if we just used the average for the other and spread that across the dwellings of all sizes. So whenever the red bars are underneath that dashed line, it's saying people who are either mostly Asian or European are underrepresented relative to their average, and whenever it's over that dashed line, they're overrepresented. So it's telling us things that we know intuitively already. It's telling us things that we have a lot more large large dwellings with Pacific peoples than we do with European and Asian peoples in them, and that's true in almost all of the age groups until we get into that 60 plus age group, where, and this is another trend that's showing up here, you notice that dashed line and also the height of those red bars is creeping up as you go up the age groups. That's telling you that as your population gets older, it's also getting whiter, and that's just that's mortality rates there. So if we want to make a model, we should make a model that tries to represent some of this age structure within dwellings for interaction patterns. Similarly, we want to look at things like there's heterogeneities in how different alert level interventions might be applied. So let's say we want to look at what's the effect of reducing transmission in workplaces by asking people to work from home. Maybe you're going to say, in this scenario, 50% of people are able to work from home. So we've got our individuals, they're linked up to their dwellings that they live in, and they're linked up to their workplaces. It's our toy model here. So there's 2 ways we could try and get that reduced transmission through workplaces. The first thing would be if we say, okay, about half of the people are going to try and work from home. We don't know which half, so we're just going to go and make each one of those links between the individuals and their workplaces half as strong. There's half as much transmission that happens in workplaces. Everyone's still connected to their same workplace, but there's just not as much transmission going on there. The alternative would be, we could say, actually, we're going to break half of those links between the individuals and their workplaces. So we go and, in this case, we've closed 2 of those workplaces, and the people who were working there, they're working at home now. They don't have that link to their workplace, that interaction context anymore. And obviously it matters. We could choose a different 2 workplaces. So we could have chosen the other 2 workplaces when we're closing half of them, or a different combination. And you can see there's consequences, if I just flick between those, for how those dwellings are connected up. So we look down the bottom here, we've got these dwellings. They're connected not because people are living in 2 dwellings, but because people who live in those dwellings go to the same workplaces. That left pink square there is joining up people from 3 different dwellings, and the other square on the right joining up people from another 2 dwellings. And so that structure of who gets connected, or who's interacting with who, changes depending on which workplaces you shut down. So, a consequence of that, this is again a toy model, set up 2 situations here. One that looks like that first scenario, where we keep everyone connected to the same number of workplaces and we just reduce the spread in all of those workplaces. And then in the second one, we break some of those links to the workplaces, but we don't reduce the spread inside them. And we do it in such a way that you get the same average amount of, should get the same average amount of transmission reduction. Except what we see coming out is that in one case where we keep all the workplaces open but just reduce the transmission in them, we get, this is showing number of infections over time, we get this situation that looks like elimination. So those lines are flattening off. And you look there, the total number of infections you're getting, it's around 800, compared with in that other situation where we're breaking some links but keeping other links open. So we're not getting elimination, those case numbers continue to grow, and your total number of infections is up in the tens of thousands. So there's an implication there, and there's a message here as well about where that risk of spread is. The people who are still going to work in a physical workplace and aren't able to work from home, that's the sort of risk that they're seeing, that in this case 10,000 infections, compared with if we were able to actually reduce the transmission in all of the workplaces. Maybe this means mask wearing in your workplace, or good clean air ventilation, getting a much lower number of infections. Right, and so this was sort of trying to lead into where we got to with effective estimates of vaccination. So vaccination's another thing that we're going to see these heterogeneous effects. Vaccination coverage is going to be clustered in different ways. So it's not just, it's sort of even worse in the situation that Daniel presented, where we are getting a wrong estimate for who is vaccinated. We're also, if we have a wrong estimate of who is vaccinated, on top of that it's knowing that unvaccinated people are more likely to be linked in with other unvaccinated people, and vice versa. And so we're going to make pockets of high infection risk and pockets that are protected, so that the consequences of overestimating your vaccination coverage is that you're going to leave these groups of connected people that are unvaccinated and more at risk. But they're connected groups, they're not just randomly spread groups. So I think I can skip through. This is the nasty, wordy version of what Daniel presented. This slide, the only point to take away from it is that your local vaccine coverage looks very different when you use either at HSU population denominator on the right. It's got much more pale colours, much more rosy looking, and so lower counts of unvaccinated individuals compared with if you were to go and use the estimated residential population, that chart on the left, which has many more blue areas where you have large numbers of unvaccinated individuals. Let's get through that. That's the nasty version of Daniel's nice graphical presentation. Daniel covered those as well, just the points that there's 2 things to worry about. One is the people who are missing from your population denominator, and the other one was that there are people who are misclassified in your population denominator. Right, so you might think at that point that this is old news, because we had a whole Waitangi hearing in December about the issue of the vaccine rollout for Māori, And it was pretty decisive in its ruling. It laid some pretty direct findings on the government, basically saying that the rollout had been inequitable, that data hadn't been available or hadn't been considered that led to an increase in risk for Māori because it was more difficult for Māori to be vaccinated, and because it was not clear who was vaccinated, and that things had not been resourced, and that this did not follow the principles of Te Tiriti. And you think, okay, so surely the government's learned from this. They accepted those findings, they've moved on, they've started doing other things. Surely that's the end of this, right? Well, so we can jump forward now. So we're not worrying so much about vaccination rates anymore. But in January, we had Omicron arrive in Aotearoa, and we've had COVID spreading all around the motu. And we've had these really high numbers of confirmed COVID cases. And you think, okay, so we can go and look at that, and surely we'll see in that, or surely that we can look at that and we can say, what's the impact been for Māori, what's the risk been, and all the rest of it, and we'll see the usual bad stories that we might see, but at least it's been quantified correctly this time, right? Except there's this issue that all we know about is the number of confirmed cases of infections. And this is not the same thing as the number of true infections that have occurred. So the way that a infection becomes a confirmed case is you need to go and you have either a PCR or a RAT test, and that result gets recorded somewhere in a national database. At that point, you've got one count of a person who has a confirmed COVID infection. So obviously, if people aren't getting tested, then they're not making it into those confirmed case counts. How do you get tested? Well, in the start of the outbreak, you had to drive to your nearest PCR testing station, and if you live in suburban Auckland, that might not be too bad. It might have been an inconvenient long wait in a queue, but you could at least get your way to a testing station. If you live in northern Tairāwhiti though, then maybe it's a 3.5 hour drive to get to that testing station. And so we're going to see exactly those same issues that played out in making it difficult to get vaccination numbers spread around Aotearoa in an equitable fashion. They're going to affect the recording of those infections as confirmed cases. So this, one obvious consequence of this is that you have a significant undercount of your number of infections or your number of cases. But another consequence of this is that those case numbers are how we determine, or how the Ministry of Health determines, where support goes. On one hand, at the level of individuals, where you lodge a confirmed case and you're supposed to get a text message that says, do you need any support? And they deal with you directly. But at a bigger picture level, that's also how different DHBs or different health providers have a picture of what resources they need to be providing and where. It's also how we know what the true infection risk is for people in future. And then looking even further down that timeline, this is how we know where infections have been in the past. We know that a significant fraction of people who've been infected are going to, over the coming year, have symptoms of long COVID. So this is things like, that looks like chronic fatigue and inability to work as productively as they might have previously. And so knowing where you've had infections tells you where you're going to in future need to support people for recovery from long COVID. And so given that we don't know where these true infections are, we don't have a way of determining where that support's going to need to be in future. Now the way that knowing true infections is tricky, because having information about confirmed cases is one thing, trying to measure infections is another. What some other countries have done to try and get a good handle on this number is to carry out what's called an infection prevalence survey. So this is going out, and it's not problem free, but it's again an improvement on just letting people report their own cases and letting all the biases and access and equity issues creep in that way. So this infection prevalence survey means you go and you design your population sample to be representative, and you send out to each of those people some type of test. They report back in that test result, and you make sure you look at the results that come back, and you make sure then that you've got enough sample for the right people in the right places in order to make sure that you are correctly sampling the population. And obviously lots of issues around how you do that sampling, still likely to undersample or deliver poor results for Māori and for people in more isolated communities and for older people and all sorts of other groups, but it does better than just saying, hey, you've got to go and report your own confirmed infection. So, I'm going to stop here and just finish back up with those three super high level points that we started with. Basically, that our traditional analytic results or traditional modelling and analysis approaches don't consider heterogeneous patterns. They don't consider ethnicity a lot of the time. When those better approaches do exist, they're only as good as the data you've got, and that data is pretty crap, to be honest, a lot of the time. And whether that's coming from things that you measure as part of a disease surveillance, or whether it just comes from background information around just knowing what your baseline population is. And there's been this sequence of things we've learned over the course of the pandemic, where this poor population data and poor data in general has led demonstrably to an increased risk of health consequences for Māori, first from under-vaccination, and now we're in the process of repeating this issue with even lower quality data on our estimates of who is infected. So I'll stop there. We wanted to make sure we allowed plenty of time for questions and korero. And I'll stop sharing.
Excellent, Dion. Thank you very much for that. There's some interesting information. It's quite sad information, really, I think, about how the government how the government's strategy with the vaccination rollout and with the infection rollout hasn't really taken at all into consideration the situation for Māori. What I want to do is I want to open it up to ask if people have some questions. So I have a couple of questions myself, but I'd rather wait to see if there's any questions coming out of the field. So if people have got any questions I'd like to ask Dion or Daniel, please unmute and feel free to ask them now. Or alternatively, if you'd like me to ask some, type your question in the chat and I'll follow that up. Okay, so any questions out there? Oh, because I have a question. So
it means we were either really clear or really confusing, right?
Yeah. So Dion, you talked about the models that have been created, homogeneous models, as if for all one population. Why haven't we created one model for like Pākehā, for instance, and one model for Māori? What's prevented that happening?
I mean, partly it was that New Zealand was not well set up for an infectious disease outbreak. So the homogeneous model that's been used a lot, it was designed with great intention. It was designed really quickly, and so that was all built, or the guts of it was built in February 2020, and we didn't have an existing capability. So part of the problem behind this is, not only that we didn't have capability for doing things and addressing issues for Māori, but it was that we didn't have capability for addressing things for infectious disease at all, or for human infectious disease. Turns out, actually, if we had we were much better placed to deal with an outbreak of an animal disease. So New Zealand is really worried about spread of foot and mouth disease with cattle, and we'd had that M. bovis spread previously. We've got amazing animal infectious disease modelers. We just didn't have that same capability when it came to human infectious disease. And it's much easier to build a model that that assumes everyone's the same, assumes that we've all got the same contact patterns of Pākehā, and not even of New Zealanders. It's like a lot of that data that's behind it is from the UK, so it's not even good for Tauiwi. And building more detailed models, and we've kind of got there, but they're slow and they're cumbersome and take resourcing and take good quality data, and we've kind of got to a point where we've built a model that's getting close to as good as we can make it for the quality of the data we've got, or at least we know there are some gaps, and are working on them, but it's preparedness.
Okay, so we weren't really prepared. We're prepared to look after our cows, but we weren't prepared to look after our people. I'm actually like cows myself, so I'm almost okay with it. Is there any examples from international modelling that we could have used or that are being done that, specifically look at data and recognise the difference between two ethnicities or ethnicities?
Yeah, and not so much around the disease spread modelling, but there's been a bunch of work that's been done overseas around just estimating transmission risk. And so Emily Harvey, who's on the Te Matatini o Te Horapa project with me, is on this. We're just talking earlier about what some of those key factors are. So there's things like, we know that there's increased risk of people working in particular industries. We know that large dwelling sizes are associated with increased risk. We know that that income or socioeconomic factors are big increases in risk, and these are kind of obvious things as well, and you can just pick them up out of the international literature and say, yeah, they're going to apply to New Zealand the same as they applied overseas, and we haven't really considered those in our response either. So I think an example of where that's shown up in the COVID response was we gave support to businesses to get them through the pandemic, but we didn't give support to individuals. So if you had to stay home from work, and in that first lockdown period, your employer got some money and they were supposed to pass that on to you, and some did and some didn't. But now we've got a situation where people are allowed to be going back to work. If you're sick and you don't have enough sick leave allocation, what are you supposed to do? Are you supposed to stay home and not get paid? Or are you supposed to go to work and infect people? Or maybe you're not sick yet, but you're in a household with a lot of people who'd be incredibly vulnerable. You're living with maybe people who are older or who have underlying health conditions. Are you supposed to go to work anyway and increase your risk of bringing home something to those people? And we know that that's going to disproportionately affect people who are on lower incomes, or on people who are working multiple jobs. They're going to twice as many workplaces, for example. And we really haven't, in the government's COVID response, seen anything that's addressed that. So the first simple thing would be giving direct support to individuals when they're infected, as opposed to supporting businesses. We've supported businesses much better than we've supported people. And even Australia is an example of doing that, supporting people directly better than what New Zealand's done. I guess it's concerning when you look up and Australia's the slightly less racist, more equitable response.
Yeah, that is a concern. If you look at Australia's history towards their Indigenous people. Okay, so moving forward, so it's clear the government in its response to COVID haven't really considered equity issues, haven't really considered Māori as being different to non-Māori. One of the ways that we could improve that clearly, and this is something that you talked about a little bit as well, Daniel, is the data. If we had better Māori data, then we'd have a better indication of, the issues that Māori are facing. So we're in this position now, if we wanted to look ahead and think, okay, so moving forward, how could we improve the situation? How could we design models that work for us as opposed to working for the general population? And so, clearly one of the items is, having better Māori data. Have you got any and this is to both of you, Dion and Daniel, have you guys got any inkling or any thoughts about how we could improve Māori data, especially Māori health data, to ultimately improve Māori health? Maybe you
go first, Daniel.
Yeah, okay. Daniel. Okay, can't unmute.
I just got unmuted by the host, so that's good. I mean, some of the discussion around the vaccine reporting. Andrew was talking about, the importance of quality data at a local level. You can have certain things going on at national level, but the picture can look quite a bit different locally. So there's a lot that's sort of working on central databases, but empowering communities a bit more and having some way of having local control over local data and investing in that, being able to network that. I don't know, this sort of seems a bit out in the future kind of stuff.
And I think there's maybe the hope that, if I was being optimistic, that we might see some of this in future with the shake-up of the DHBs and moving towards two health provisions at a national level, the one for the whole country, but then also specifically a Māori health organisation that might be a little bit better about directly resourcing Māori health agencies. So the thing that kicked off that Waitangi Tribunal case was Māori health organisations not being able to get access to information about who was and wasn't vaccinated. They'd already done the work, they'd got their vaccination buses out there, they wanted to be going out and doing work on the ground, and they couldn't get hold of the data, as bad as it was, to go and improve things. And so maybe if in future we see, like the current situation is each DHB sort of does their own thing in terms of data collection or data management for what happens within the DHB, and that has its issues, but it works for some DHBs. You can imagine something like that happening internally to Māori health organisations, and them being able to then respond better to needs of that, whatever their particular communities are. And that's not the same thing as everyone having the resources and the capability and the time and everything else. And sure, you've got your risks of fragmentation, but it does at least take some of that out of the hands of central government.
Yeah, I kind of, the more and more I see issues happening for Māori, with health, with education, with a whole bunch of things, technology, the more I think the best solutions are kind of solutions that Māori provide for themselves, and with their own iwi, within their own rohe. So, maybe that's one of the big takeaways. We can't rely on the government to look after Māori. As Māori, we've got to look after ourselves. And given that Māori are inherently iwi-based, as an iwi, we've got to look after ourselves. So, I guess that's maybe something going forward. If there's no other questions, I have two things that I'd like to do. The first thing is the mihi atu kia kōrua, tēnā kōrua. Thank you, Dion. Thank you, Daniel, for taking the time, first of all, to acknowledge we do have a significant issue here. The models that we are creating aren't really models that are built for Māori. The data that is being collected is quite poor data. And, the ultimate result is that Māori are being thrown under the bus pretty much. So, kei te mihi atu kia kōrua I whakatakoto wera tūmanu whakaaro. So thank you too for laying those thoughts out there. Thank you too for taking some time to explain all of these issues. I've been told to say a reminder that te mana raraunga virtual wānanga is going to be held in May, and we'll have another opportunity to discuss some of these issues here. So keep an ear out for the Te Mana Raraunga next wānanga. Nō reira, tēnei te mea atu kia kōrua, I te mea I timata I te karakia, kōti te karakia. Nō reira, unuhia ki te uru tapu nui kia wātia, kia māma, te nākau te tinana, te wairoi, te arataka. Koe rā e rongo whakairi aki ki runga kia tīna. Haumi e hui e, tae ki e. Kia ora tātou.